Welcome to ICU Fellowship Prepcast.
Hi, I'm Maddie.
Hi, I'm Swapnil, and today we are going to discuss another fellowship snippet. So, Maddie, the scenario is you have a 58-year-old morbidly obese woman who is admitted to intensive care unit following out of hospital cardiac arrest. The arrest was witnessed and she had a bystander CPR, and it was continued for 20 minutes until the ambulance arrived. The initial rhythm was ventricular tachycardia or VT, and she had a single defibrillation attempt with return of spontaneous circulation. She was making non-purposeful movements in emergency department prior to getting intubated, and then subsequently she was sent to cath lab. She has returned to intensive care unit with the following vital signs: heart rate of 90 beats per minute, sinus rhythm, blood pressure of 95/55 millimeters of mercury, and a temperature of 37.8 degrees Celsius. Can you please outline your approach for initial assessment?
So the initial assessment involves history, examination, and investigative finding. So from the historical point of view, I'd mainly like to know about her background, the details, further details of the arrest, and then the details of the in-hospital treatment that she's received so far. So from a background point of view, if it's known, if she has any other comorbidities, any cardiac risk factors such as diabetes, hypertension, and also it says that she's morbidly obese, but what her current weight or BMI is. If she's on any medications, does she have allergies? And her social history, including the next of kin, which would be important to liaise with, and her functional status, and if there's any history of drug or alcohol or smoking. From the arrest perspective, we know that she had initial bystander CPR immediately, but what the quality of the initial CPR was, and if there's any signs of either from the collapse or from the CPR and resuscitation itself. The treatment given in the ambulance. So she had ROS with the ambulance, but did they need to do anything else? Any antiarrhythmics or adrenaline or any sedation given? Her vital signs and GCS, including the breakdown in the ambulance. Then from an in-hospital perspective, this would be divided into the details in ED and the details for cath lab. So from ED, the vital signs were there, and her GCS. So we know she was making non-purposeful movements, but what was the actual GCS and the breakdown of that? Any pupillary abnormalities, the grade of intubation, and any medications given, especially things like antiplatelet, and ECG findings in ED. From a cath lab perspective, what was used for the angiogram and the sheet site, the hemodynamics throughout, whether there was any more arrhythmias or VT, if there was a culprit lesion identified and if intervention was performed, the amount of heparin given in cath lab, if an echo was performed and what the EF was, or if there was any other abnormalities, and if there was sedation that was required during cath lab and when her last paralysis was given, and any issues because she was ventilated throughout with her ventilation or oxygenation status. From an examination point of view, this would mainly surround looking at complications from her arrest and from the treatment that's been provided support up so far. So from a respiratory perspective, looking at the ETT position and patency, the ventilator settings, and the assessment of any difficulty oxygenation or ventilating her, and any abnormalities on auscultation. From a hemodynamic perspective, if there's any signs of shock after this arrest, so right or left heart failure, if she's needing any hemodynamic support to maintain this blood pressure, the current access that she has, the angiogram access site, and looking for any complications such as a hematoma or bleed, her end organ function, so urine output, and echo to assess the cardiac function and regional wall motion abnormality if not performed in cath lab. And from a neurological perspective, the GCS currently, if she hasn't been paralysed or sedated, the pupillary abnormalities and the presence of any brainstem reflexes currently. From an investigative point of view, it'd be bedside test bloods and imaging. So bedside would be doing an immediate ECG, looking for the post-cath lab ECG and any ischemic changes. An ABG to look at her oxygenation, ventilation, and metabolic parameters, including lactate, which might give some clue about her cardiovascular status. The electrolytes and her glucose, mainly in terms of both her renal function and also in terms of maintaining sort of normal parameters post-arrest. Bloods, including a full blood count to look at her hemoglobin and platelets, so she probably will have antiplatelets. UEC for the electrolytes and renal function. CMP for electrolytes to optimize to avoid arrhythmias. LFTs for any signs of ischemic hepatitis. Coags because she's probably received heparin. A group and hold if she hasn't done that, and a troponin. And from an imaging, the chest X-ray for an ETT position, NGT lines, and any complications, so rib fractures from the CPR.
Thanks, Maddie. So while you're doing the assessment, the further information was provided to you that she's known hypertensive and diabetic. And also in cath lab, she had a drug-eluting single stent was placed in a culprit LAD lesion. So what are your management priorities over next 24 hours?
So my management priorities for this patient involves optimizing her organ function, targeted temperature management, post-coronary intervention management, and general supportive care. So from an optimizing organ function, I divide this in terms of hemodynamic, respiratory, and BSL control. So from a hemodynamic perspective, I'd want to make sure that she has adequate monitoring and access, so central and arterial access and IDC to monitor urine output and full cardiorespiratory monitoring. I'd be aiming a MAP of 65 or more, using noradrenaline initially, but if there's any signs of cardiogenic shock with end organ impairment, such as decreased urine output, rising lactate, or a decreased EF on echo, then to start some milrinone. And then treating any arrhythmias. So I'd want to optimize electrolytes, generally aiming a MAG of over 1, a potassium of 4 to 4.5. If there is VT and amiodarone bolus of 300 milligrams, then an infusion, and then followed by lignocaine bolus and then infusion if there's refractory VT. From a respiratory perspective, I'd be giving a higher peak, so generally around 10, given her morbid obesity, but then titrating that to oxygenation and also depending on the hemodynamic status, aiming sats of 92% or more and a PaC2 of 35 to 45, and aiming transition to a spontaneous mode of ventilation. And then from a BSL control perspective, we know that she's got poorly controlled diabetes, so checking her ketones and BSL and an insulin infusion, initially aiming to normalize ketones if she is ketoacidotic, and then aiming a BSL of 6 to 10. Although this would also depend on what her initial BSL was, so I'd avoid dropping BSL by more than 5 millimoles a litre if she was hyperglycemic to begin with. And if her BSL was very high, like over 30, or if she was hyperosmolar, I'd aim to keep the BSL around the 10 to 15 range for the next 24 hours. I'd also be doing targeted temperature management, so avoiding fevers, aiming a temperature less than 37.8, measuring core temperature using a bladder temperature probe, regular paracetamol, ice packs if she was getting febrile, then a feedback-controlled surface cooling system if that was available. And then from a post-coronary intervention perspective, she needed an NG or OG and dual antiplatelets for the drug-eluting stent, and monitoring the angiogram access site for hematoma or bleeding complications. The final aspect of management for this first 24 hours would be the supportive care. So sedation and analgesia initially while she's paralysed, if she was just paralysed prior to cath lab, and then wean to assess the neurology. Sedation might need to be maintained if she requires active cooling to maintain normothermia, but will also depend on the neurology. So if she does become alert and appropriate, she might actually, some patients are appropriate for extubation within that first 24 hours. But if there's any, poor neurology, she might need, or inappropriate neurology, she might need a little bit of sedation or analgesia. If she did have any lateralizing neurology, she would probably need a CT scan to exclude complications, especially in the context of having DAPT or heparin for angiogram and having this collapse. So may have had a brain injury as well. I'd be doing gastric feeds, PPI, DVT prophylaxis, and a family update and social worker input, given the sudden and traumatic nature of this arrest.
Thanks, Maddie. So one of the salient points provided in this patient's history is that she is morbidly obese. So can you please outline how patient's morbid obesity may impact her management in intensive care unit?
So I think this can affect all systems and it can have logistic implications. So from a systematic approach, cardiovascularly, we know that with morbid obesity, there can be significant difficulty with both venous and arterial access, and as a result, also increased risk of complications. So central venous access and arterial access might actually be required for longer, given potential issues obtaining peripheral venous access and appropriate sizing of a non-invasive cuff. There's an increased risk of peripheral vascular disease, so that might also add to the difficulties with arterial access and increase the risk of pressure areas. It's also difficult to clinically examine and ascertain the fluid status, so it can lead to either under or over resuscitation of these patients. And we know that she has ischemic heart disease, which increases risk of complications and potentially reduce ejection fraction and multi-organ impairment. We also know she has hypertension, so she might have a more variable response to sedation and catecholamines, and there's also an increased risk of stroke. From a respiratory perspective, if there is issues with her current endotracheal tube or a failure, say she requires re-intubation, fails extubation, more likely to have difficult bag valve mask, and the Endoscopy is perceived as more difficult, but it's actually been shown the grade's often not difficult, but the positioning is difficult for patients with morbid obesity. She's also likely to have higher airway pressures, decreased compliance as the obesity acts like a restrictive defect, and increased propensity for atelectasis, increased incidence of sleep apnea and pulmonary hypertension. And all of these factors cause difficulty weaning from the ventilator. If she does progress to a stage where she's thought about needing a percutaneous tracheostomy, this is often quite difficult anatomically. And she also would have an increased risk of DVTs, PEs, but it's also that's compounded by the difficulty in diagnosing the same clinically. From a gastrointestinal point of view, she's got increased risk of fatty liver disease. So the hepatic metabolism of some drugs might be impaired. And it's also tricky to calculate the appropriate nutritional requirements. So this might result in underfeeding for her. From a other system, endocrine, immune, and hematological perspective, patients with morbid obesity have a chronic inflammatory state, and things like the baseline CRP levels are often elevated in obese patients. We know she has poorly controlled diabetes, so it might be difficult to have glycemic control, and she's at increased risk of things like infective complications and pressure areas and skin breakdown. And the optimal dose of things like DVT prophylaxis is unclear. So we might, if she's having Clexane, might need to use anti-10 levels for the to ensure adequate dosing. And from a renal perspective, there's an increased risk of renal impairment. Pharmacologically, drug kinetics are more difficult to predict, and drug dosing calculation may be inaccurate due to differences with her ideal body weight or an actual body weight. And she might actually need larger doses of medications, which increases the risk of adverse effects. And then logistically, there's increased staff requirements for repositioning and pressure area care. Imaging such as ultrasound, chest X-ray, CT and MRI can be difficult. And there's also the psychosocial risk of that increased risk of stigma actually from staff and other people caring for her.
Thanks, Maddie. Quite a challenging problem to deal with in intensive care unit. And often this whole debate about whether to aim for ideal body weight or lean body mass or which weight to go by while you're calculating the drug dosage or dialysis dose is often quite tricky. And obviously there is the obesity paradox, which is so challenging to deal with. Often said that we think that obesity is pretty bad, but often these outcomes are, again, not totally hopeless. So even the ventilation seems to be challenging, but actually in real life, the ventilation is not that difficult in these patients. If they get ARDS, the outcomes are usually better compared to non-obese counterparts, which is kind of funny. There are certain things that are good with obesity, but clearly the dealing with logistical challenge in intensive care unit can be quite challenging. Especially, as I said, the imaging part of it, especially with MRI or CT tables can take certain weight or certain girth, body habitus. And if you can't perform those images, we have a limited information to go with. Now, on your ward round, your registrar has asked this question because this patient came to emergency department after assessing out of hospital VT cardiac arrest and went to cath lab straight away. So what's the kind of evidence for this approach where patients who had out of hospital cardiac arrest had to go to cath lab?
So it depends on the population, but for patients who have had a cardiac arrest with ST segment elevation on their ECGs, almost all of them will go for coronary angiogram immediately, unless there's an obvious alternate cause for their arrest and ECG changes, such as like they've got a subarachnoid hemorrhage or something, or there are contraindications or it's thought to be like a non-survivable injury. The group where there's been more discussion surrounding the utility of immediate coronary angiogram post-resuscitation are the patients who don't have ST elevation on their ECG, but have no other obvious cause for their arrest. So we know that the most common cause of cardiac arrest is ischemic heart disease, but it's not the cause of all arrests. And the optimal timing of coronary angiogram in those post-cardiac arrest but without ST elevation is uncertain. So immediate coronary angiogram may delay things like targeted temperature management, optimal organ support of the patient, and might exacerbate things like acute kidney injury, and it might not actually provide a mortality benefit but cause complications and might subject patients who are unlikely to survive to unnecessary procedures. But conversely, immediate angiogram might identify culprit lesions even in the absence of ECG changes and might help to exclude this important cause of an arrest. There's several trials that are present. The earliest sort of randomized controlled big trial in this space is the COAPT trial in 2019, which was a randomized controlled trial of 552 patients. And all of these look at cardiac arrest without ST elevation and randomize them to immediate or delayed coronary angiogram after neurological recovery. And there was no difference in the survival at 90 days. But it was, like, again, unblinded. It was limited to one country, the Netherlands, and it was powered for a 40% difference in mortality, which, like, when we think about ICU interventions and investigations, that's very rare that there's something that will result in a 40% mortality. Like, that would be an amazing treatment or intervention to perform. Hemodynamically unstable patients were excluded, and coronary intervention was actually performed in less than 40% of patients, and acute unstable lesions were found in 20%. The next trial was a smaller trial in 2020 called the Pearl trial, which was a pilot study of 99 patients, but it was terminated early, so it was underpowered. And it randomized early coronary angiography versus no early angiography in all comers resuscitated from out-of-hospital cardiac arrest without ST elevation. And there was no difference in their primary composite endpoint, which was a composite of survival to discharge, favorable neurology at discharge, and EF of greater than 50%, and normal wall motion score. But that was quite a small trial, and that was underpowered. The next bigger trial was the Tomahawk trial in 2021, which was a multi-center RCT of 554 patients. And they found no mortality benefit at 30 days between those who were randomized to immediate or delayed angio. Again, it was not blinded, and it was powered for a 12% absolute difference in 30-day mortality, which is also high. And there was a high rate of crossover from the control group to the coronary angio group within, so less than 24 hours. Then in 2022, we have the Emerge trial, which was randomized patients, 279 patients. Again, the same criteria, out of hospital cardiac arrest without ST elevation to immediate or delayed, so within 48 to 96 hours of coronary angiogram. And they looked at 180-day survival rate with a cerebral performance category of 2 or less, and there was no difference between the groups. But once again, it was underpowered and performed in one country, and it stopped early due to lack of enrollment. And only 37% of the patients in the delayed angio group received the allocated intervention. And there was a higher rate of witnessed arrest and bystander CPR in the delayed group, which might have confounded some of the results. And there was more non-shockable rhythms and more women in the delayed group. So there was also demographic differences. And then finally, the COOP trial in 2022 was a very small trial of 69 patients with out-of-hospital cardiac arrest without ST elevation. And they found no difference in the composite endpoint that they used of in-hospital survival and 6-month cerebral performance category score of 2 or less between the immediate and delayed angiogram groups. Then there was a meta-analysis in 2020 of 11 studies, which totaled 3,581 patients, and they found no difference in the 30-day mortality and neurological status between the early or the delayed coronary angio group. So basically the evidence, even though the trials, there are critiques of them, the best evidence that we have shows that there's actually no difference in either patient-centered or things like mortality outcomes between having a delayed coronary angiogram or an immediate coronary angiogram in those that don't have ST elevation on the ECG post-arrest, which has kind of made it more, it's something we think about more before just embarking on doing a coronary angiogram straight away in this patient population.
Thanks, Maddie. So that's a very comprehensive coverage of all the evidence around that. And I guess one of the things that we are doing nowadays more frequently is to perform a CT brain prior to going to cath lab, or sometimes even CT chest with contrast. We had a recent case, which is interestingly, there was a dissection which was kind of type B, distal to subclavian, and then obviously got missed, but I went for coronary, and in the meantime, then later on found out to be extension of dissection. These are the kind of very small cohort of patients which will pose the clinical challenge, where either patient has subarachnoid hemorrhage and STT changes, or patient with aortic dissection with a retrograde dissection into coronary and then cause similar changes. And then you subject them to cath lab or anticoagulation, and then the outcomes will be quite opposite. So again, they're not very big percentage of these patients will have those problems. Be mindful or be cognizant that there are some other pathologies which can mimic like ST elevation MI. And that's why performing some of the other imaging studies prior to cath lab might be useful. Always the balance with that is delaying the cath lab procedure, which always time is the muscle, and we have to get to the cath lab in under less than 90 minutes is important. But at the same time, I think if we have a ability to perform CT scan on the way to cath lab, I think it's not a bad idea to do it. Coming back to intensive care management, patient is in ICU for now more than 96 hours, remains intubated with a GCS of E1VTM2. And you've been asked this question by your nursing staff. What's the next step? What do you think about what do you think about her prognosis?
So neuroprognostication in this patient requires a multimodal assessment at the appropriate time. So generally earliest is at 72 hours or 72 hours after rewarming if they were cooled, and excluding confounders such as sedation or severe hepatic renal failure, paralysis. So my assessment would involve consideration of historical examination and investigative findings. Historical findings in terms of neuroprognostication are less useful and haven't been shown to correlate with individual outcome, but they're good in terms of the multimodal assessment to paint more of a picture of the prognosis for this patient. So in terms of the events surrounding their arrest, she does actually have some favourable features from a historical perspective in terms of that she had the initial rhythm was VT. So we know that there's a worse prognosis with PEA or asystolic arrest. It was a witnessed arrest with immediate bystander CPR, and that time to ROSC was less than 30 minutes. So they're all more favourable aspects. But she is older with multiple comorbidities, which does convey a worse prognosis. And I'd like to find out a bit more about her functional status prior to the arrest and other comorbidities, which might help as a prognostication. From a clinical perspective, timing I think is appropriate, but I'd want to exclude other confounders and then perform a full neurological exam. So she has a motor response of 2, which has a low specificity but high sensitivity for a poor prognosis. I'd want to check her pupils and her corneal reflex. So absence of them has a poor prognosis, especially if she has absence of both. I'd look at whether she'd had the presence of continuous and generalized myoclonus lasting for 30 minutes or more, which that also conveys a worse prognosis. And I'd check her cough reflex, which isn't statistically associated with a poor prognosis, but in this context would be worrying in terms of brainstem function and also her ability to be extubated. I'd also want to look at her cardiovascular and respiratory status, how much ventilation and oxygenation support she's requiring. Is she on a mandatory or a spontaneous mode of ventilation, and the amount of inotropes and pressors and other complications from her arrest and stay, especially things like multi-organ impairment, which together helps to give an idea about a prognosis. Then from an investigative point of view, the morbid obesity might make some of the imaging challenging, but ideally seeing if she'd had a CT or an MRI, and if there was findings of a diffuse or extensive anoxic injury, that's a poor prognostic feature. An EEG showing a malignant pattern such as suppressed background or burst suppression. And I'd like to check her organ function such as her UEC, LFTs, looking especially for a GCS for any confounders, but also for signs of, in terms of if she did have severe organ failure, that would also make me concerned in this context for that she has multi-organ failure and is 96 hours post this arrest. In my practice, I know like a lot of the books and stuff say things about neuron-specific NLAs, but we don't use it in my institution and we don't actually have access to it. But I guess it's good to know that that exists and it has been and is correlated with worse prognosis depending on the amount. And we also don't have easy access to somatosensory evoked potentials. It's good to know there are specific guidelines about neuroprognostication, such as the ERC or ESICM guidelines. And there are a lot of resources online to have a look at because neuroprognostication is be really tricky.
Yeah, that's correct. So as you rightly said, this question will come into Viva format, written format, or even you will have a hot case where you've been asked to comment upon what's your thoughts on patient's prognostication. It's always going to be history, examination, and investigations. And as you said, the history that you obtain at the beginning, total downtime, bystander CPR, effective or not, the cause of the arrest, reversibility, and then overall comorbidities, age, frailty. You have to put everything together in that context. You can't just use 1 or 2 investigation or 1 clinical examination on day 4 or day 5 as your definitive answer for this question. So we do use now neuron specific knowledge because we do have access to perform it. So we add that into the tools that we have in addition to MRI, EEG, CT scans. We always try to perform now MRIs and EEG prior to commenting on neuroprognostication. Again, the more information that you gather is always better. And ultimately, you still tend to go with the clinical picture that's in front of you. Because if it's like day 10, day 7, like day 10, day 14, and patient's still not waking up, it's very unlikely that they are going to suddenly wake up after 4 weeks. So yeah, you have to put a lot of things into that kind of context. One of the things that we have moved away in general in intensive care community is to avoid practicing self-fulfilling prophecy. Just because this patient had a prolonged cardiac arrest, or just because I don't think this patient is going to wake up, we don't try to withdraw anymore within first 72 hours. All the LCOR guidelines, ARC guidelines do advocate that you have to probably wait for that at least 70 to 96 hours now. And you cannot, just because the patient had a myoclonic jerks in first 24 hours, that means the prognosis is bad.
Yeah.
I think the myoclonic jerks are increasingly proven to be not 100% association with poor outcome. So that's also important to keep in mind. Performing the EEG, and that's why it's very important, because if the patient is in status epilepticus or patient has got a seizure activities, it is important that address adequately prior to embarking on the neuroprognostication. So all the reversible causes need to be addressed prior to sitting down with the family. The message that you give to the family is also quite important. Sometimes that uncertainty needs to be communicated adequately to the family. And then guiding them through this journey is one of the things that most of the intensivists will find challenging in their career. So I think how you address the uncertainty and how you manage the family is also important part of managing the out of hospital cardiac arrest in your unit.
Yeah, it's also getting an idea about, I mean, it depends on the level of disability for this patient and stuff, or whether you think it's survivable or not after you do neuroprognosticate with all the information. But then sometimes, even if it's survivable, they might be left with a very significant level of disability, which might not be something they had wanted previously, or just they discussed it with their family before. So it's also important to get an idea of what this patient was like before and what their values were. And
yeah, that's a really important point. And also with MRI, a lot of people think that MRI, even if you perform the MRI at day 5, day 7, that will show hypoxic brain injury. If MRI doesn't show, that doesn't mean the patient doesn't have hypoxic brain injury. And that's not the case, because MRI sensitivity is also only 70%. So in 30% of the cases, even MRI might look normal, but patients still showing clinically signs of hypoxic ischemic encephalopathy. So every investigation comes with its pros and cons. And I think it's important for us to understand what's the specificity, what's the sensitivity of each investigation. And that's why combining all the investigations together is more useful to get to the as close as possible to the certainty level. You can never be 100% certain that this patient is going to live or not, but at the same time, you will have a fair bit of idea about whether the patient will reach to the baseline neurological status or not. So I think there are a few aspects of out of hospital cardiac arrest that we are learning as we mature in the specialty. Simply is important to avoid self-fulfilling prophecy, gather as much information, keep the clear communication. So thanks, Mani. That's the end of our today's snippet. We'll be back with another snippet in a few weeks' time. Till then, goodbye and have a nice time.
Thanks for listening. See you next time.